Management and outcomes after upper versus lower extremity vascular trauma. This is presented by Lindsay, Gallo, and colleagues from Emory University in Atlanta.
Hi, my name is Lindsay Gallo. I am currently a fourth-year medical student at Emory University, and today I will be discussing management and outcomes after upper versus lower extremity vascular trauma. I have nothing to disclose. Traumatic injury remains a leading cause of death in the United States. While vascular injury is less lethal when occurring in the extremities than in central body regions, peripheral vascular trauma is frequently associated with concordant injuries and thus presents with unique challenges to injury management. Possibly because of these complex injury patterns, survivors often suffer poor functional outcomes and long-term disability. The scope of existing literature on peripheral vascular trauma is limited, though. Most current studies explore either injuries to the lower extremities or injuries to the upper extremities. The vast majority of these investigations focuses on trauma to the lower extremity vasculature, despite the fact that upper extremity arterial injuries comprise 30 to 40% of all vascular extremity injuries. We aim to fill this gap with our study, which uses the largest reported patient series obtained from review of a single institution's ACS Level 1 Trauma Center registry to directly compare injury characteristics, surgical interventions, and functional outcomes of upper and lower extremity vascular injuries. We performed a retrospective analysis of a single institution's electronic medical records for all patients 18 years and over diagnosed with traumatic peripheral vascular injuries requiring surgical interventions between January 1st, 2011 and December 31st, 2019. Indications for surgical intervention included active bleeding or ischemia of the involved extremity. Our study included 535 patients, with 234 of them undergoing repair of upper extremity vascular injuries. Patients with upper extremity injuries were more likely to be female, have a pre-hospital tourniquet applied, have associated nerve injuries, or present with bleeding. However, vascular injuries of the upper extremity were less commonly associated with concomitant fractures. In regards to operative management, upper extremity injuries were more likely to be managed with vessel ligation and were less likely to be managed with interposition venous grafts or vein orifices. They were also less likely to be associated with concomitant fasciotomies. Post-operatively, upper extremity injuries were associated with persistent nerve deficits, while lower extremity injuries had a higher incidence of 30-day limb loss. There were no significant differences in mortality, unplanned vascular-related reinterventions, or 30-day readmissions. So in summary, upper extremity vascular injuries were more likely to present with active bleeding and preoperative nerve deficits, and then more frequently managed with vessel ligation. Upper extremity injuries are associated with a lower limb loss rate, but have an increased prevalence of nerve deficits after trauma. This brings up the question of why these functional deficits are seen. It is possible that because upper extremity vascular injuries less frequently present with ischemia and have lower rates of limb loss, there may be a delay in diagnosis which could affect functional outcomes. The complex presenting injury patterns resulting from the concordant injuries seen with peripheral vascular trauma may also contribute to these functional deficits. Regardless, it is paramount to maintain a high level of suspicion preoperatively and intraoperatively to identify associated nerve injuries and to improve long-term functional outcomes. Thank you so much for listening.
Okay, nice to see some vascular trauma on the session, and we're open for questions now. Let me start. Did you have any patients that had burns associated with their traumatic injury, and were they excluded or identified or specifically analyzed? Seems like that's a pretty common associated injury with these extremity traumas sometimes.
That was not something we recorded. I noticed that when I was going through the electronic medical record, there was one or two that did, but we did not actually look at that specifically in our study.
Dr. Velasquez would like to know, Do you have information on whether these injuries were managed by vascular surgeons versus trauma surgeons?
So we did not look at that either because there's previously published data from Emory in 2018 that 75% of the cases were done by vascular surgeons. So we didn't look at that in our study.
Who does fasciotomies of the upper extremities? I noticed you said fasciotomy was much less common. Is that an availability of a hand surgeon issue, or do you think there's a little bit of a bias against doing fasciotomy for that reason?
Yeah, it's an interesting question. I think that's actually an area we're hoping to look into and do some more studying about that. Most of them, from what I recall, were not done specifically by hand surgeons, though. Most of them were done by the team, whichever team did the primary repair.
Dr. Sharon Kang would like to know, did you look at injury severity scores in these patients, and did that correlate with the outcomes you evaluated?
We did. I did record the injury severity score. We did not specifically see if that was correlated with the outcomes, though.
I was sort of wondering too, one could imagine just mechanistically, if you have an upper extremity injury instead of a lower extremity injury, you might be more likely to have a C-spine or a traumatic brain injury. Was there any associations with a pattern of injury apart from the vascular injury like that observed?
So those are also kind of factors we reported and looked at, but did not specifically evaluate in terms of whether it was a brain associated injury versus a spinal injury. But yeah, yes.
Dr. Zuka wants to know, what about the need for venous reconstruction or bypass instead of arterial? Was that more likely an arm injury?
Sorry, can you repeat that question?
It was just regarding the nature of the vascular injury and whether venous injuries were more common versus arterial in one location versus another.
Oh, I believe we did not see any significant difference between the location and venous versus arterial.
Greg McGee would like to say, lots of the upper extremity injuries were ligated. Were these mostly radial and ulnar artery injuries?
Yes, they were. And I think that accounts for kind of why there were so many higher rates of ligation in the upper extremities.
You're getting lots of questions, which is a good sign. It means this is an interesting topic. So hang with me. You're doing a good job. Dr. Jason Kim, did you look at the etiology of the trauma, and did it have any impact, say, if it was a penetrating versus sharp versus missile injury?
Yes, so we looked at the etiology. We did penetrating versus blunt, and then within penetrating versus blunt, kind of further divided or specified the injury. We did not note any significant differences, though, between the type of injury and mechanism and outcomes.
Dr. Sharon Kang says, were the perioperative metrics discordant between upper and lower extremity injuries, and specifically asked about Glasgow Coma scale and time to the OR and things like that?
Yes, so we looked at the Glasgow Coma scale, did not find any significant differences in that. Time to OR, we did not specifically look at, though.
Jason Lee would like to know, could you tell over time, was there a trend toward more hybrid or endovascular approaches to the repair over the series?
Not that I've noticed, no.
Dr. Matt Smeds wants to know, did you look at follow-up? Do you know what your median follow-up was? And he points out that trauma patients notoriously have awful follow-up and are frequently lost to follow-up. Did that affect your outcomes?
So we looked at follow-up, we did initial follow-up, and then looked at the date for kind of last follow-up appointment related to this injury. And we were actually kind of, I guess, impressed or like surprised by the rate of follow-up. And I believe it was like around 40% of patients ended up having at least one, not necessarily more than one, follow-up appointment.
Dr. Zukow wants to know, was anticoagulation and or antiplatelet therapy used in these patients post-op? Was there any difference in the medical management for arm versus leg injuries?
So that is something we looked at. We looked at intraoperative anticoagulation as well as postoperative aspirin administration and anticoagulation. And then we also looked to see if long-term at the follow-up appointment, if the patients were on those as well. For this current study, though, we didn't specifically kind of look at the differences between or compare the differences between patients who were taking their anticoagulation or got it in the hospital versus those who did not.
With this being such a relatively young population versus what we see, in our atherosclerosis patient cohorts, I was curious, do you have the ability to look at things like ability to return to work or being employed? I was sort of curious whether patients with an upper extremity injury, particularly if they had a job that required manual labor or typing on a keyboard, might be more likely to be disabled. You may not have looked at that, but it might be a really interesting thing to explore in the future.
Yeah, we did look at kind of on their follow-up appointment, like functional ability and long-term kind of functional ability. We didn't specifically, I guess, look for in terms of work in specific, but that is something we looked at. And the main kind of inhibiting factor was for upper extremities was nerve deficits, but and then so that is something, but we're like hoping to study more functionality after trauma in another project.
You did an outstanding job. That was the highest question to length of talk ratio. It'll be hard to top, I think, over the rest of the meeting. So congrats on that, and we'll let Dr. Zukow introduce our next speaker.
Thank you.